Great. Thanks everybody for joining this third one. I was asked to just give a quick update, but very clear. It's not a sales talk, and it's good to be able to disclose that I'm actually not a salesman, but I've to spend a lot of time on that. So, the Leo Cancer Care's base product is the Leo Marie system, which is a CT scanner wrapped around a upright patient positioner, and we all know about this. And now the question is, who knows about this? Just yesterday, we received a 510(k) clearance on the device, and there's the man. The K number. His number in the race was our K number, and I don't know what the time means. Stephen queried me this morning about the 9 hours, so maybe it's 900 days. I don't know how long it was, but it was for sure a momentous effort. So what does this mean? It means the entire patient positioning arm of radiation therapy is now FDA approved, and now other vendors can come and just add the radiation beam to it, which is, of course, with Mevion, and you'll hear a lot of the discussion today with Mevion and other partners. But anyhow, kudos to Dan Farber that made this presentation, and BJ taught me how to use AI, so I was able to AI shop Stephen's face in there. So where do I need to point to? Say again? Point that way? To advance? Okay. The first speaker always has the problem with... Okay, there we go. So here is just the first 3 clinical partners. So we, of course, have 6 installations going, but we still hope that we will go clinical before the end of the year at Stanford with the Mevion Fit machine. At McLaren, we're putting 2 of the Leo systems in an empty gantry vault, and that is scheduled to go clinical early next year. And then Baycare is also under installation, various phase installations. So those are the 3 centers that we think will go clinical still in 2025. That highly depends just on state regulations, state approvals in the state of California. A disclosure I did not do is that I have way too many slides. So when my time is up, I'll just stop, right? Here we see a huge amount of clinical partners in protons, in X-rays, in flash electrons, in carbon ions. And just want to highlight this here. I think this is a laser. 27 clinical partners right now. We have working on many, many more. We hope to eclipse that number by another several into the 30s by the end of the year. 6 unit installations. But here's an important number, is that we calculate based on that 27 contracts, we save the industry around about $350 million total customer savings in terms of total product cost. So that's a huge impact that we have on industry. The next big thing that we launched now at Astro, and now we can start talking more freely about it, we have FDA approval, is to add a LINAC to the patient position, and that's our product called Grace, and several of you guys in the audience is part of the Upright Photon Consortium. But you can see here, again, the laser is not very clear. In the bottom right here is the bunker, and that was a couple of months ago. Second one on the bottom is the bunker that we put into our facility in London, in the office in Crawley. And top left there, can you see how incredibly small this LINAC actually is, right? So the LINAC now is just a modular unit to the Marie system. The multi-leaf collimator appears to be extremely big. That's the one on the top right picture here. But several of our folks, the folks here from Cone Health, PJ and team, will receive their system towards the end of the year. And also at Mayo Jacksonville, that's the 2 installations in the United States where the Grace system will go into. So we're really excited about that development, man. A little bit on image guidance or the image quality of the CT scanner. Here we just see a leg of a pork or a ham, a big ham. We needed to try and find something that represents pretty much a clinical environment. You start imaging solid phantoms, doesn't give you the full story. So we're getting close. A great paper presented by Dr. Glider's team from UW kind of already showed that the first version of the scanner we delivered to him is pretty much fit for treatment planning in photons and protons, but we continue to work on the image quality of this side. A little bit on pediatrics. I presented several times in the past, and I still believe that this will be the way of treating pediatrics in the near future. So the first concept was, can we just put a child seat on top of the positioner? And can we do like on the right where the patient would be leaning forward for CSI treatments? So here's the CARE design of the backwards tipping device. You would just tip the patient backwards, change the direction of the gravitational force, then immobilize, anesthetize, and then tip into the treatment position. But the very important thing is, what if the patient has an emergency during the treatment? In that case, you would just tip the patient backwards and get access to the patient, rip off the mask and everything. So this is very well received by the industry. The next one is the CARE design of the forward-leaning devices. So this is what we have in mind here, that your custom device have lean the patient forward, primarily indicated for CSI treatments. But I can't see why you wouldn't eventually do everything in this posture. And here's just the prototype that we are now building in the UK office, just out of wood. Doesn't have to be radio translucent, it's just to test form, fit, and function. And we just entered into a research agreement with St. Jude, C3. Dr. Chen is here. Please talk to him, but we will install a temporary positioner for them so they can work with real patients going through a immobilization exercise in upright position, also using distraction. I have to show this upper part. It was not done yet. Yes, and in fact it is done, but Simon forgot to send me the picture. But this is like a little forward face mask that goes in on that section, right? Another thing that our colleagues from Stanford came up and said, you know what? Could we, for a very small kid that still fits into the bore of the scanner, could you have a situation where you tip the baby up by 30 degrees and then tilt the scanner 15 degrees in the opposite direction? And on the left picture there, you can see the scan planes and the proton beam would come in. And this could be a very elegant way of treating just intracranial cases. And actually went further and say, what if I put a patient on a degrader slab and I can actually treat a proton CSI in this way, right? So this is for kids less than 3 years old, less than 36 centimeters in total length, still fit in the bore diagonally, and we should actually be able to treat a CSI patient effectively that way. This is all, I should have said, this is just a futuristic thinking. Where are we going? What's the science behind it? Where should we go? I'm also developing a very comprehensive QA detector. What you see on the left there is a device based on scintillator with a plastic mirror, and you can irradiate the device in both directions. The idea is you put it on the Leo system, you scan every morning this device, you test the image guidance system, you test the beam, you test every single aspect of proton therapy on a daily basis. And what you actually get is, on the left here, I just show an image of required at the proton machine where the device was deliberately misaligned. So you're basically doing image guidance with the beam in the backward direction, or you do image guidance with the X-ray in the forward direction, deliver the beam and see if you're in the right place. This device is absolutely unique and going to revolutionize QA in the radiation therapy space. It's in prototype stage. The first unit is going to go to BJ's team soon by, I keep on shifting date, but it should be now somewhere in August, right? Okay, I forgot to change the zoom angle thing. I don't know why this thing keep on zooming out, but this is a slide from Eric Engwall. Just want to say a couple of words of arc therapy. There is no question that arc therapy in all radiation therapy beams is so much easier by just rotating the patient. But what it really means is how should we deliver arc therapy in proton therapy space? Everybody in the proton therapy space says, you know, you shouldn't do arc because you're spreading the low-dose bath. But that's actually a wrong statement. If you deliver the arc in such a way that all the beams into the target are mutually exclusive, and here on the top right you see a distribution, it's just a proof of concept, but you can push the optimizer a little bit harder and get a really good distribution still for that target. But if I renormalize and I'm looking at what happens in the healthy tissue, you can see now you end up with having spatially fractionated radiation in the healthy tissue, which then totally counteracts the impact of the low-dose bath. We know the impact of spatially fractionated radiation and radiation side effects. So I'm really excited about developing this as the next step in terms of arc therapy. It's just not arcing, it's arcing in a way that makes clinically sense. This slide, I'm not sure how I'm going to play it. This is just a picture of how we envisage a craniospinal treatment in the mammalian system. So the entire patient is in the beam, it's one registration, and then you just walk through the beams. and then you do the posterior oblique fields for the brain. But why not arcing over the brain and then linearly, continuously translate along the spinal axis? So the next step that we all need to work together and for everything is to not only do arc therapy, but also doing translational therapy. So while the beam is on, you might as well slide the patient in the beam, and then when you get to the brain, you just do a little arc. So this technique will take a craniospinal test to way less than 10 minutes. Right now, craniospinal treatments, and John will allude to their first cranial trial treatment soon this afternoon. So I'm really excited about taking craniospinal treatments down to the sub 10-minute level, and that's really possible. The other thing we can do is progressive adaptation, and I'm just going to accelerate through the slide here. Typically, why not? If we have the CT scanner at IsoCenter every day, why not start treating with a patient that is good enough for the first treatment, improve in 24 hours, improve in 24 hours, and after 72 hours, you have the ideal plan, you keep it ideal. So that's a goal for research. There's many more information here I have to click through. The next one is, now who can help me? Anthony, can you just go back to the second to last slide? No, that's the first slide. If you, one more. Yeah, sorry for all the clicks. Autonomous treatment. So if you look at that picture on the left, if you have a manual stick shift car and you're reading your emails and everything, you really need all those lanes. You can see all the cars are all over the place. But if you go to self-driving cars where the cars are driven by cameras, we can actually develop much narrower lanes. I mean, let's ignore the fact that you need big trucks as well, but you can technically go with smaller lanes. And the same then applies to radiation therapy. If we can do autonomous treatments, do a daily correction based on the CT at IsoCenter, we can really start treating with much narrower margins. I'm out of time. I'm going to accelerate through this slide. I knew it's going to happen, but please come talk to me afterwards. Harold Paganetti basically made the statement that was way back in 2016 that we have not reached the ultimate use of proton therapy, and what was needed was stuff like proton arc and optical guidance and the CT at IsoCenter. And we believe this is all easier in the upright position. And that is really the message I want to leave you guys with. I'm not going to spend much time on the summary, just say that adoption of upright is in full swing. The benefits of the entire radiation therapy community is huge to providers, to patients, and to vendors. Upright radiation that will finally allow us to use protons as protons. That's that slide from Paganetti. Means tighter margins, and upright radiation that will enable autonomous treatments, online adaptations / progressive adaptation. So I will stop here and entertain a couple of questions if there's any.
Thank you very much, Nick. So if you have like a time maybe for 1 or 2 questions, so please. Okay, so it was probably, yes.
Just free my emeritus professor at the University of Wisconsin, they too have an installed system and have for about a year. It's going to be deinstalled and moved to the proton site. So there's actually, I guess, 4 machines installed at 3 sites.
Yeah, I think the slide says there's 6 installations. That includes them, but there are 3 that I mentioned there is the ones that go clinical. And of course, there's about 4 presentations by Kerry's group about the work, and I apologize I didn't explicitly mention them, but I had so little time to fill it in, right? Okay.